I'm Elisha Paul de Koning, an emergency physician at Dartmouth-Hitchcock Medical Center and a contributor to Tintinalli's Access Emergency Medicine. The shoulder is the most frequently dislocated joint we encounter in the emergency department, and while anterior dislocations are by far the most common, here we will focus on the management of posterior dislocations. Posterior dislocations require a mechanism of adduction and extreme internal rotation. The classic presentation is after a seizure or electric shock, and can indeed be missed in the initial evaluation of the post-ictal seizure patient, or by misinterpretation of radiographic imaging. A direct blow can also produce this injury. Patients with posterior dislocations hold the injured extremity in adduction and internal rotation and resist external rotation and abduction. The anterior shoulder is squared off, as in anterior dislocations, and the coracoid process is prominent. Bilateral posterior dislocations are not uncommon owing to mechanisms of seizure or electric shock and will have a symmetric appearance. The humeral head is palpable beneath the acromion with fullness to the posterior shoulder. In posterior dislocations, the AP view may have the appearance of a light bulb or ice cream cone on X-ray. The scapular Y view shows the humeral head posterior to the glenoid, the Y. In the axillary view, the golf ball has fallen posteriorly off the tee. Posterior dislocations can be challenging to reduce, and in some cases they require open reduction. But this is not a contraindication to attempted reduction by the emergency physician. Additional imaging, such as computed tomography or MRI, is not routine and should be at the discretion of orthopedic consultation. After making the diagnosis, obtain informed consent, gather needed medications, and, if necessary, equipment for procedural sedation. The indication for procedural sedation is multifactorial and depends upon the method you choose to reduce the dislocation, patient comorbidities and preference, as well as the need for urgent reduction. The details of procedural sedation will not be discussed here. In the patient that does not require procedural sedation, consider intra-articular injection of lidocaine to reduce patient discomfort and thus aid reduction. In some cases, this may be all the analgesia necessary. Reductions take time. Rushing the procedure is likely to only add to patient discomfort, physician frustration, and the likelihood of a failed reduction. In the posterior dislocation of a left shoulder, loop a bedsheet in the affected axilla. This is for countertraction. A second bedsheet is placed in the antecubital fossa while looping it around the operator's foot like a gas pedal. Gentle axial traction is applied by pressing on your foot like a gas pedal. Gentle anterior pressure on the humeral head assists in relocating it over the glenoid rim. Some slow external rotation of the arm may be needed to assist reduction. Place a looped bedsheet in the affected axilla. Next, place the patient in the supine position. A second bedsheet is placed in the affected antecubital fossa, holding the elbow at 90 degrees. Leaning backwards provides axial traction. The assistant provides countertraction. Gentle external rotation of the forearm reduces the humeral head from the glenoid. Classically, a palpable clunk signifies a successful reduction. Patients should remain in the sling until orthopedic follow-up. typically within 5 to 7 days. NSAIDs may be used for outpatient pain management. Opioid analgesics will likely be needed for breakthrough pain.